Okay, so I thought we can start with the fact that I had taught an exercise course this past weekend, a DNS exercise course this past weekend.
Mhm.
And when we get to the topic of how DNS describes primary stability, primary
Mhm.
spinal stability, primary
Mhm.
sagittal plane stability, I
Mhm.
generally just have the slides up on the screen with the information, but I'll sit down and I'll tell them the story of how sagittal plane stability develops over time and how
Okay.
DNS describes it. So I thought, they, after I did it, I asked them, does this seem like you understand what's going on? And they agreed. And I said, you should be able to tell this story and repeat the story to yourself and to your patients or your clients. So I thought I might tell you the story and then we'll see, how you agree with how I'm describing it. Maybe you disagree
Okay.
with some things, or maybe you have a different way of describing some of these things.
Okay.
Okay. So
Yes.
let me teach Robert Lardner about primary sagittal plane stability of the
Please,
spine.
please do.
So,
Please do.
um, this primary stability typically begins or should be solidified by about 3 months old. So, from a newborn to 3 months old, essentially newborns have absolutely no stability whatsoever, no ability to control. And that's exemplified in their posture and their inability to have any kind of purposeful movement.
Mhm.
At about 6 weeks, the midbrain starts to take over a little bit, and you start to see some control starting to develop. Whether that's the ability to kind of, in prone, lift the head off the ground through a little bit of support through the forearms, whether that's a little bit of abdominal wall muscle coordination that starts at about 6 weeks. From 6 weeks to 3 months, the baby in supine is essentially practicing and training all day long on their back that the abdominal
Mhm.
wall muscles will
Mhm.
coordinate their activity with the respiratory diaphragm as well as the pelvic floor or the pelvic diaphragm. This coordination of abdominal wall muscle activity not only is acting as like a control and a resistance against abdominal wall expansion caused by respiratory diaphragm contraction,
Mhm.
but the abdominal wall muscle coordination acts to pull the rib cage down, altering the posture and
Mhm.
essentially placing the child, the spine, the lumbar spine, the pelvis, the thorax in a better relationship and a better, more effective posture to actually generate the intra abdominal pressure or the IAP that
Mhm.
is necessary and sufficient for what DNS would describe as primary sagittal plane stability. That process begins at about 6 weeks and should be solidified by about 3 months old in both supine and prone. When you're in supine at 3 months, this is exemplified by an elongation of the lumbar spine, a lowering of the rib cage a bit, and the baby will then be able to lift their hips and legs up and off the ground under control.
Mhm.
In prone, this is exemplified by, again, that elongation of the spine, a lowered rib cage, a creation of intra-abdominal pressure, which allows the baby to support through the epicondyles of the elbows and lift their head up against gravity. So that is generally how I would describe it. I would kind of say that, again, the source, the actual like definition of where the stability comes from is the intra-abdominal pressure that is created through the coordination of the abdominal wall muscle activation with the respiratory and pelvic diaphragms contracting.
Okay.
What do we think about that?
Well, I would add the erector spinae as the
Okay.
completion of the canister. So the gradual coming online of stabilization is the interplay of the two diaphragms, the whole wall container, which includes the abdominal wall, and the posterior wall, which includes the erector spinae. And that is how the IAP is created to stimulate stability of the spine. But I think your explanation is as good as it gets in terms of explaining what we're expecting to see. I think that everything gradually comes online and strengthens, and as the basic stabilization becomes more and more secure, we see an increase in the repertoire of the extremity function, and also a change and a maturation of the posture.
Yeah. Okay. So, like, I mean, and when we talk about, or when you're mentioning the erector spinae,
Mm-hmm.
just to overtly say it, you're obviously not talking about like a concentric activation of the erector spinae. You're talking about, I would almost think, a eccentric activation of erector spinae. There's increased tone to the erector spinae that is being facilitated by the abdominal wall expansion. Is that what you're saying?
I would say that there's a balanced activity between agonist and antagonistic functions of the components of the canister, whether those are concentric or eccentric or isometric, because they change depending on what the baby is doing or what he wants to do. So I cannot rule out one, the concentric or eccentric function. You have access to all three: isometric, concentric, eccentric functions. The important thing is that they are balanced and opposed by the synergists and the agonists, so that no one group dominates the stability to the disadvantage of the others or causes over compression of the spine. The intra-abdominal pressure itself helps to limit how much concentric activity can occur within the wall of the canister by creating a distractive force by virtue of compression.
That is an interesting way of thinking about what intra-abdominal pressure is doing. That it's acting, just like you said. I mean, it's acting to kind of distract things, literally into traction or distraction, so that you can't overly concentrically contract. And that's yeah. I mean, and that's a little bit, I guess. I never thought about it that way so much. I always just kind of defined it as the source of stability.
I see.
Versus thinking about the whole thing is the source of stability. And intra-abdominal pressure's role is to kind of, for lack of a better term, kind of keep the abdomen distended so that it's not sucking in. Because when you get the activity of the erector spinae as well as the abdominal wall muscles, if there's nothing to kind of fight against, they'll just suck in. Everything will suck in. So and that's why I kind of, when you mentioned the erector spinae, I know that's not what you mean, and I know that's not what I would think, but I hear erector spinae contraction or activity, and I think hyperextension of the lumbar spine. And that's obviously not what we're talking about. Yeah.
Yes. Pavel mentions the distractive function, and I think in some of Richard Alm's presentations, he elaborates on the decompressive nature of intra-abdominal pressure, which is required for good balance and minimizing or avoiding overloading of the discs and the spaces between the vertebrae. So I think that is really important. We really have to maintain this interplay at all times, and I think that is one of the challenges for the patient to get to appreciate that it is not just the abdominal wall or the erector spinae that he must feel, but more in terms of a sense of a canister, a lower abdominal circular sensation of tension, which can be regulated, but should not be so much that breathing is challenged.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.